everyone. Thank you for joining us for this week's Case of the Week. I'm Kara Borzecki, the Credentialing and Education Coordinator. And now I'd like to introduce our speaker and fellow of the Academy, Dr. Emily Mostafavi.
Hello, everyone. Thank you for your brief introduction. And thank for AAID and Educational Committee to make this forum possible. I think COVID has had a positive impact of making it possible for all of us to realize that although we could be miles and miles away from each other, we can still connect virtually and communicate with each other. I'd like to share my experiences and learn from you as well. A brief introduction about me. I graduated from Anamala University Dental School in India in 1992. I then went to Iran and I graduated as a DDS from Shahid Beheshti Dental School. I started restoring implants in 1991, and I soon realized that I do need more unbiased, non-commercially oriented education in implant dentistry to be more successful. Lucky enough, I joined Mexico's India 2005, and having benefited from the education that I received from AAID, I then started working on providing the same type of education to the Iranian dentists. So I initiated and I was the clinical director of AAID Iran Mexicos, which ran from 2010 to 2014. I joined the residency program at University of Rochester, Eastman Institute for Oral Health in prosthodontics, and I graduated in 2018. I became an associate fellow of the Academy in 2010 and a fellow of the Academy in 2013. So that's a brief introduction of it. The case that I'd like to present to you here is a mixture of implant, fixed pros, all-on-4 kind of concept, and there are interesting things that I think I'll be happy to share with you. So let's start. So let me go back here. All right, so I would like to start my presentation by reviewing the case, reaching a diagnosis, talking about the treatment planning consideration, and then how I developed the treatment plan that you will see. And based on that, then treatment sequencing, I do a prosthetic workup, and then we move on as now that we have our path forward, we move on to the surgical phase, the restorative phase, and ultimately maintenance of the case. So here our patient is Tom. Tom is 69 years old, Caucasian male. He's retired, he's single. And in Haas classification, I would categorize Tom as being a philosophical patient. His chief complaint being, I have neglected my teeth for a long period, which is good. At least he is admitting to that. Now that I'm retired, I want to fix my teeth, and I also have pain in my right lower side. So when I see a patient for the first time, I do have a questionnaire which has only 4 or 5 questions on it, and I do gain a lot of information and insight into the patient. I would like always to get a one-to-one connection into the mentality of the patient and realize what the patient's expectations are before moving forward. So one of the questions that I ask the patient is that, why did you make a call for this appointment today? Like in this case, as as you will see in the next few slides, he has been dealing with a lot of issues, dental issues. I, as a clinician, like to know what was the main concern that the patient called in. That gives me an insight if the patient is simply looking for a quick patchwork kind of a thing, or no, he has not realized the extent of the problems that he has, and he is now looking for a comprehensive treatment planning and a comprehensive treatment. Why? Because the comprehensive treatment cannot be successful, in my view, unless and until the patient is committed to the long-term prognosis of the case. So here we have the medical history of Tom. He has hypertension, for which he is taking all these medications. He has a cardiac stent placed in 2009, no drug allergy, and I categorize him as a class 2 patient. Dental history is significant for the part that he hasn't been on a regular dental visits in the last few years. The last time that he has been to a dentist was 3 years ago. And as far as he remembers, he had an extraction, a surgical extraction of the wisdom teeth 35 years ago. He does know that he has bilateral impacted maxillary canine, which from the day one, he was very, very specific in saying that I do not want to remove these teeth. Probably he has some bad experience with the surgical removal of the wisdom teeth. So the extraoral examination says that he has a rectangular to oval face. His face is symmetrical. The upper third of the face is relatively longer than the lower and the middle third. The TM joint was good within normal limit, no deviation, no crepitus, no limitation in mouth opening. He does have a small mouth, I should admit, and the examination of the lymph nodes was negative. So here is the intraoral view from the frontal. As you can see, there's a lot of restorations, recurring decay, decalcification of the margins of the teeth. Luckily, the positive finding is that we have enough keratinized tissue, and he has, I would say, a rather thick tissue biotype. Protrusive view. Right lateral maximal intercuspation, you can see the occlusal plane is not an ideal occlusal plane. The left maximum intercuspation. Occlusal view of the maxillary arch. Occlusal view of the mandibular arch. The periochar of the maxilla. No bleeding on probing, not much of sulcular depth, luckily, but in the mandibular arch, you see that almost on all the teeth, we have bleeding on probing and various depths of sulcus, some pocket, perio pocket. The FMX, you can see here the impacted canines. Anterior IOPAs, posterior PA radiographs, the pulpal involvement of the second molar in the right lower side, left PAs, bite wings, panoramics that gives us an overall picture of where the patient stands. In my review of the panoramic X-ray, I always like to start from one side and go to the other side. That way I make sure that I'm not missing any significant finding. So I usually start from the right side. I go down the mandible from right to left, and then I come back focusing on the maxillary arch and sinuses. So the CBCT view, which clearly shows the mesioangular impacted canines. Here's the diagnosis. I'm not going to go through all these items, but I made a point to clearly delineate to the patient what the diagnoses are and what are the problems that he is having. To brief you on it, he has recurring caries, primary caries. He has pulpal involvement in 31. He has a retained root, 2 retained roots, in fact. And he has high caries risk index according to the Canberra classification. Maxillary canines, we talked about. His angle classification is class 1 with deep bite and crowding of the lower anteriors. Now, in developing my treatment plan, I would consider the findings, diagnosis. I would strongly consider the patient's desire. What are the main objectives of the patient asking for the treatment? And what are my limitations? Now, limitations could be anatomical limitations. It could be financial limitations. There could be time limitations that the patient has. So all these I would consider in my treatment planning. The patient has been seen for multiple times, many different aspects of the treatment, many different treatment plans were proposed to the patients. Basically, whether the patient desires and it is acceptable in long-term prognosis to either save the teeth. If so, what treatments are involved? What are the financial implications of the treatment? What is the time that it takes for the treatment to be completed, and so on and so forth. And if not, if the teeth are going to be extracted, then what are the options that the patient has? So all these were discussed in detail in multiple visits that I saw the patient in order to come up with a mutually agreed treatment planning that the patient would be happy at the end of the treatment. As I said, patient expectation in this case was that he was looking into having a treatment with a high predictability, less complications, a long-term prognosis, and he did have positive he did want positively to maintain his upper posterior teeth, upper molars. And for sure, as I mentioned earlier, he said no question about removing those impacted canines. So those were his limitations. Then I would consider the age of the patient. Is it at this age, is it a better option for the patient to maintain what he has, restoring the teeth with all that it takes? Or is it more appropriate in terms of investing in time and financially to choose some other treatment option rather than maintaining the teeth? In terms of, I consider the high caries index, I strongly considered while considering the long-term prognosis of the abutment teeth, if the patient would have decided to maintain his teeth, then what would be the outcome and what would be the long-term prognosis of the abutment teeth under the crowns in cases like Tom with high caries index? Would he change the lifelong, rather moderate to poor, I would say more towards being poor oral hygiene? Would he change his behavior after so many years? So these are the questions that have to be answered before I finalize the treatment plan. Now, the treatment that has been finalized and agreed upon and the patient accepted and asked me to move forward is shown here. Now, before all that, we did mention and we did take it up upon ourselves to educate the patient on the need for his dietary change and an improvement in his oral hygiene. So ultimately, the treatment that was proposed was in maxillary arch. He decided to maintain the molars, extraction of the remaining teeth from premolar to premolar. And then, again, as I mentioned, he decided that he does not want to remove those impacted canines. In case of mandibular arch, a decision was made and agreed upon for total extraction and implant supported fixed detachable complete denture. So now that we have a treatment plan, let's talk about the treatment sequences. The treatment sequence, in my belief, is very important for all concerned to be involved because it sets the timeline, it sets the steps that are included, it explains to the patient what their expectations at each stage of the treatment has to be. So in case of maxillary arch, I decided based on what my CBCT and radiographic findings told me that it is not possible to go in for extraction and immediate placement. A rather wise option would be extraction, socket grafting, let the healing take place, preserving as much bone as we could, clear up all the things, and then placing the implants. In the lower arch, you may argue that why not go in for extraction and immediate placement, which could be right. We could do that too. But I decided to considering the age of the patient, I considered to do it not to rush things, but rather to take the upper jaw and lower jaw treatment at the same stage, at the same speed, in order to synchronize and be able to plan my occlusal plane more efficiently. So I decided to do whatever teeth has to be extracted in both the arches, putting the patient on an interim set of dentures. I also decided, at least till the end of the treatment, to maintain the second molars, which would help me greatly in maintaining my vertical dimension of occlusion throughout the treatment. So I staged the treatment as phase 1, extraction, socket preservation, and delivery of the interim provisionals. Stage 2 would be after the healing of the sockets have taken place, placement of implant, and then I decided on having restrictive guided surgery for the maxillary arch for the reason that I decided to have full arch implant supported dental prosthesis, which is a screw retained. And as you all will agree with me, for a screw retained full arch fixed prosthesis, we need to make sure that the implant access holes are in the right positions so that we do not want to have an screw access hole coming out of the labial. So for that reason, I decided to scan the case with a properly made surgical guide, the scan guide, sorry, and then go ahead by placing the implants through a restrictive guided surgery. So is not the case with the lower arch. With the lower arch, I propose to do a fixed detachable complete denture, commonly known as a hybrid. So in case of a hybrid, all I need to know is where all I need to know is to be sure to place my implants within the confines of the prosthesis. So I use the non-restricted guided surgery in case of the lower arch. So these are the CBCT of the impacted canines that I had to somehow bypass them in placing my implant in the anterior region. So the other proposed areas for implant placement, as you can see. And so each side for implant placement was evaluated by a CBCT, and I measured how much bone I have to remove in order to be able to place my implant where I needed to place them. The prosthetic workflow goes into these following steps. So interim dentures to provisionalize after extraction so that the patient is comfortable eating and speaking, doing his normal function during the healing phase. At the end of the healing phase, now that my upper and lower ridges are healed, now I make a new set of impressions, and I do make a new set of interims in ideal prosthetically driven positions based on the healed ridges that I now have after the healing is completed. Based on that, I scan the patient for fabrication of the anatomic surgical guide in the upper arch. And as I said, I maintain the second molar teeth in the lower arch till the end of the treatment in order to have a stable vertical dimension of occlusion. So the prosthetic steps, so extraction and socket grafting in both the arches and the interim dentures, which is relined by a soft reline material. In this case, I used the co-soft from GC. So healing of the arches is taking place. So here I made a new set of teeth. And the point that I like to mention here is that because I wanted to make sure how my lip line will be supported, I removed the flange from the teeth set in order to be able to evaluate exactly how the lip support would be. I did not want the flange of my scan guide to kind of give me a false lip support. So here is the frontal view, and the 3D printed of the maxillary arch and the restrictive implant guide that you see. So implants are placed in both the arches, the Straumann. Post-surgical radiographs. You see here that I was lucky to kind of bypass and be able to place that single anterior implant in spite of the canine being present here. So our fixed provisionals, after the initial healing had taken place, what I did was I made the patient a set of upper and lower fixed provisionals, which were implant supported, and I delivered it within 2 weeks of the implant placements. And you see that our friend is very happy now that he has something fixed in his mouth. 3 months down the line, after implant placement, we go ahead with making the final impression of the lower arch, as you see here. Verification jig made on the mastercast, verified that my impression of the implant is as accurate as it could be, so that I can work on the cast. Titanium framework trying. So the impression of the upper implants, verification jig, framework trying, and centric relation record. Or patient in repose with his final, a happy patient with his finals, the frontal view of the final prosthesis in both the upper and lower arches, protrusive, right lateral, left lateral view, upper occlusal. You can see the implant access holes. Lower fixed detachable complete denture. And are a happy patient. So with that, the patient is on to a journey with his prosthesis. I'll be more than happy to answer any question that you might have.
We got Dr. Liang said, very nice case, thank you.
Oh, thank you very much. Thank you very much for your time.
So at the moment, it doesn't look like we have any questions. Just a few comments. We have Dr. Pierre Matty says, very nice case.
Oh, thank you, Jack.
And so if anyone does have any questions, they can reach out to you. Thank you again to Dr. Mostafavi for sharing with us today. And anyone else, thank you for joining our webinar today. We'll be posting online if we have any further presentations. But thank you for being here. Have a good day, everyone.
Thank you very much for everyone for your valuable time in watching the presentation. Thank you very much. And again, thank you, AAID, for making this possible. Thank you. Have a good day.
Thank you.
Bye-bye.